Good afternoon, everyone. Welcome to this webinar from the National Health Council. This afternoon, we're going to talk about COVID-19, nutrition, and meeting the needs of the most vulnerable. Next slide, please, Silka. Just want to remind you that the National Health Council is a membership organization, and the largest portion of our membership is patient advocacy organizations. And here you see the logos of the 62 patient advocacy organizations that we have in membership. And we like to say that the National Health Council represents the voices of the over 160 million Americans that have at least one chronic disease or disability. We've been working this year to support all of our membership organizations in the work that they've been doing when it comes to COVID-19 and the pandemic. And we started this series of webinars to help provide information to our members and to others about COVID-19 and things that they might be participating in or would like to know that their colleagues in other organizations are participating in. Next slide, please. Got a few housekeeping items. Just want to let everyone know that the webinar is being recorded, and when we are finished, it will be available on the NHC website afterwards. All attendees are automatically muted and cannot unmute themselves, so please submit your questions and comments through the Q&A function, and we will be getting to those later after the presentations so that we'll have a Q&A session with the speakers, and we'll tap into those questions at that time. Next slide, please. The objectives today are to discuss the interplay of COVID-19, nutrition, and vulnerable populations. And we want to highlight the issues and programs that are available now, such as elderly nutrition programs, the role of caregiving, and resources for food insecure populations. Next slide, please. I'm Dr. Eleanor Perfetto, and I'm the Executive Vice President for Strategic Initiatives with the National Health Council. And it's my pleasure to introduce our two speakers today. We're going to begin with Shirley Chow. Shirley is the Director of Nutrition in the Massachusetts Executive Offices of Elder Affairs. And then we also have with us Grace Whiting. Grace is President and CEO of the National Alliance for Caregiving, which is a member of the National Health Council. So we're going to begin with Shirley, and I'm going to turn it over to her. Silke, would you just go to the next slide for Shirley?
Hi, my name is Shirley Chow, and it is a pleasure today to share Massachusetts' experience with everybody during COVID. Next. Before I start, I would like to give you a brief overview of the Massachusetts Nutrition Program. We have 25 nutrition projects across the state and serving about 9.2 million meals a year. We have 7,000 volunteers contribute a great time to the program. The program addresses multiple problems faced by the elderly, include poor nutrition, food insecurity, chronic disease, and the social isolation. Next. The mission of the program is with all the supported services in the community, we want to support the older person live independently in the community as long as possible. Next. Next slide, please. Yeah. Mrs. G is a typical participant of our program. She's lived alone. She's 87 years old with some chronic condition. And she is losing weight and have a poor appetite. After assessment, we set up her for home delivered meals at some oral nutrition supplement. We assigned 2 days to go to a community meal site and encourage her to join a local council on aging for some activities. After 6 months, she gained some weight, she's happier and increased mobility. So the outcome is very positive. Next slide, please. Then at March 2020, the pandemic hit the community. Next slide. So people in our line work face the biggest challenge we ever did. All the community living seniors quickly became homebound. Isolation and depression make the chronic condition worse and intensify the malnutrition and the frailty. Food insecurity also magnified by isolation, social distancing, and limited financial resources. So what we need to do is serving more people with a better food, good nutrition in a very short time. Next slides, please. Next slides. So The 4 areas the community response is try to ensure food security and maintain a socialization, support the family caregivers, and also raise public awareness. Next, please. So Mrs. G's outside contact almost reduced to none. So the social isolation and depression further impact on her appetite and the frailty. Next. How we ensure food security. Next. There are 3 federal relief for the Older American Act program. First is so-called CARE Act. CARE Act funded the Area Agency on Aging to support our increased demand for the community services. The Family First Coronavirus Response Act allow USDA give additional funding to the SNAP, WIC, school lunch program, and TFAP, also loosen some rules. The Older American Act for the Senior Meals Program and the Indian Health Services also have the USDA Farmers to Family Box Program. All those programs doesn't require state match, so that gives the state some flexibility to do services. One of that example is what you see is the Family First Act. The funding is supposed supplements the Commonwealth's nutrition program. But as a state, we want to maximize our buying power to secure food supply. So we initiate a centralized buying program, use portion of the fund. We start buying all types 7 days meals, frozen meals, shelf-stable meals to deliver to 85,000 high-risk clients in the state. They either need to be quarantined or their delivery days get shortened. This is a picture we take in early March. As you can see, we do not have the PPE equipment. All the community partners every morning drove the car to the nutrition project and receive the food and deliver door to door to the high-risk clients in the community. Next slide, please. Next slide. Yeah, okay. The food assistance program in Massachusetts also ramped up. The governor's food assistance task force is have like a 90 private and the public sectors representative try to map out the food assistance support. The SNAP system also have a lot of flexibility. They move to online application and approval process and also allow online purchasing. The pandemic EBT is for family have school-age children, and we have a lot of grandparents raising grandchildren also can benefit from the program. The regional consortiums formed, the large food banks, the Salvation Armies, they start partner with the local hunger relief agencies to solve the problem. Next slide. So now we see how the community elderly nutrition program is doing. Next slide. First at all, the governor added another $750,000 in the elder lunch funding in addition to the federal supplement. The nutrition program, we saw a 50% increase from the previous year. We are doing about 40,000 to 45,000 meals across the state a day now. It's a volunteer shortage because we have all the senior volunteers. Now, one time we lost about 75% of the volunteer force. A lot of school teachers at this time sign on as a temporary volunteer. We use a contact-free drop-off to deliver meals. You can see in the picture. And also if people don't get daily delivery, we make a call to do the safety check. And several regional kitchens were ordered to be closed because staff contact the virus. The neighboring kitchen will step up to pick the load. It was a time where you really saw good in people and how they show humanity to each other. Next. As the pandemic wore on, the local programs start shift their congregate dining to grab and go. This is a picture. You can tell people drive by, they give the meal, but they keep some kind of tradition. They still have July 4th car drive around and the barbecue. And Thanksgiving, they have a pie, and some local libraries start a lunch with a book to keep people interested. Next. The senior farmer program during the summertime is very popular with the elders. And this year, the farmers stopped setting up the market. What they do is the nutrition program start asking them pack individual package with fresh produce, either delivered by the farm or by the farmer or by the program to the seniors' household. And then they also set up the mobile markets at the parking lot of the senior housing complex or local council on aging. Also, it's a senior on the go bus. You can take seniors to minimal shopping. Next. Next, please. Yeah. The USDA Farmers to Family Box Program, we benefit from this program tremendously. First is the box is free to seniors. Another thing is instead the senior have to go to the food bank or our pantry to source food, we work directly with the packer and distributors so they can deliver the box directly to the nutrition program or local council on aging. Then they either deliver to people's house, you can see in the picture, or they can do the truck to trunk to pick up. In 2020, we delivered about more than 450,000 pounds food to 37,000 senior households. And the people receive it is not our meal participants. They are the local community people. Their food supply get interrupt. And a lot of veteran services join the efforts with us to deliver food. That's a combination box. Also, we have meat box. Next slide, please. Next one I do like to mention, because a lot of public housing after the pandemic, they stop letting people get out the room for safety. And in Boston alone, we have about 4,000 shut-ins. So we have to deliver the boxes door to door. The left is a combination box, the right is a meat box to the seniors to keep the food supply during that time. Next, please. The socialization, I would say the 350 towns in Massachusetts, every town is trying to do something to maintain the socialization. I use some examples. Next. The Chinese Golden Age in Boston is a Chinese program. So they transfer all their activities online. This is a Tai Chi class. They do Zoom meeting. They do ESL class and nutrition education. Next. The Cambridge, next, please. Next, the Cambridge Council on Aging, they do the Zoom art class. They teach the watercolor drawings and other things online. And they also has a virtual art exhibit. If you have time, check out. It's a lot of great artists. Next. The Dracut, they keep the whole summer, even to the late fall, have the fitness program outdoor. So the seniors can drive or the bus can pick a few of them. They keep them going on the physical fitness. Next slide, please. The nutrition education also become pretty innovative. Next slide, please. So we do the conference call. That's a low tech because not everybody has an iPhone. The Zoom meeting is great because you can have an interaction, also can do pre-post test. The cable access TV is great on cooking shows and the exercise program, and also the YouTube channel. They can host a follow-up session after the session. This is a couple example. It's a AAA. They post the nutrition education learning opportunity on their website. And next one is the Greater Springfield. Next slide, please. They post on their Facebook, on the different YouTube sites. People can take advantage of it. Next. The telehealth for medical nutrition therapy is something before COVID we were doing great on the medical nutrition therapy. We identified the people, we found the people need medical nutrition therapy, we built CMS, and we were doing great. But after the pandemic, I have to say, we were not ready for that. So all of a sudden, a lot of activities stopped. This is one thing after the pandemic, I think we will focus on. Next. I want to talk about social media. I'm older. I don't really know the power of social media. We did 3 social media campaigns during this time. First is to do a COVID check. I understand there's other states, 5 states in the country doing, including Massachusetts. The message is simple. Just call your neighbor, call your distant relative. Are they okay? Do they need something? Are they feel lonely? What you can do? And the campaign, we have 15,000 people follow the message. So I thought it was great. Then the state run a COVID-19 MA. That's the same idea is you click on the hashtag. Basically, you can navigate all the food assistance program in the state with our age group. The last one is dear to my heart is be a nutrition neighbor. We want to raise the malnutrition awareness across the state and with our ages. We did 1 week in the Aspen Malnutrition Week. We got some extra additional media attentions, but we have more than 100 followers. That was totally surprised me. Next slides, please. As you can see, we have a MIMS personalized issue of malnutrition. We have nutrition education information and informatic data to show people and try to raise the awareness. People look at you, like you and me, may be malnourished. Next slide, please. I think we have a lot of work need to do after the pandemic, but the last year we learned a lot. And that's 3 areas I want to mention. One is promote and teach online communication tools to seniors and the staff. One thing I learned is unless you are old, all the seniors is ready and willing to learn a new tool and to get on the telehealth. So we want to maximize the telehealth from screening, education to counseling. Because that, let us rethink the service deliveries. Some services may be for the community, we can bring the services to the people instead of bring people to the services and get a better result and a more cost effective. To the community nutrition program, I would say our probably across the country did a great job. But the one thing I learned is we need to consolidate the resource, more collaboration, and to get better results. I do want, next slides, want to thank a lot of people. I want to thank my office, the leadership allow us to do this, and the nutrition program, the councils on aging, the food service workers, distributor drivers, and all the volunteers. Without them, we will never be able to sail through this pandemic. And some of my personal gratitude to Johanna Dwyer, Mary Beth Arnsberg, and Carol Malone and Amy Shelley for their continued guidance. So thank you.
Shirley, thank you so much. That was great. Before we jump into Grace's presentation, we had one question that I was going to ask you, and then we'll move on. So it's from Lester Rosenwig, who says, Shirley, can people from outside Massachusetts sign up on the Facebook and Twitter accounts to get the information?
Oh, yes, definitely.
Great. Terrific. Okay, great. So let's move on. Grace, we're going to bring your slides up next. Oh, and there's some resources. We'll make these available to everyone. We'll make sure that everyone gets a copy of that.
Thank you.
Okay, Grace, we're turning it over to you. Thank you.
Yeah, thank you so much. And I'm honored to be here today and to be spending the lunch hour with all of you. And I really enjoyed Dr. Chow's presentation. And so I'm happy to partner up with her and talk a little bit about the roles of friend and family members as it relates to COVID-19 nutrition and meeting the needs of the most vulnerable. So on the next page, you'll see some background information about the National Alliance for Caregiving. I'm proud to be the president and CEO of NAC, and we've just completed our strategic planning process and updated our vision. So just to share that our vision is really a society that values, supports, and empowers family caregivers to thrive at home, work, and life. And certainly the food that we eat and the nutrition that we gain through our diet and through even family rituals where we come together for meals is an important part of that experience. Our mission is really to build partnerships in research, advocacy, and innovation to make life better for family caregivers. And we're committed to doing that in a number of ways. You'll see on the right-hand side of your slide a profile of one of the many caregivers we've worked with as part of the Raise Family Caregivers Advisory Council. This is a special council at the Department of Health and Human Services that is coming up with a national plan for family caregivers all across the lifespan. And so you can see on our website and in the forthcoming report to Congress, some of the issues and oral histories of caregivers that are in our network that represent a large group of folks who are dealing with a healthcare condition or a disability and helping someone else take care of themselves from day to day. On the next slide, I want to talk to you a little bit about what I'm going to talk to you about. Two things I think to take away. First is really identifying caregivers. Who are family caregivers? And how do we identify them in order to provide help? And that's something that I think in Dr. Chow's presentation, you kind of got a sense of is like, especially during COVID-19, how do we reach out to people? And the second is really looking at what we know from the research and from the community work that's been done around COVID-19, families, and food security. On the next slide, I want to start with a question, and I want you to think about the people in your life that you know who might be taking care of someone. This came up for me the first time I was watching. I'm a huge nerd. I love all things nerdy and geeky. So I was watching a movie about the X-Men called Logan, and Wolverine, who is a superhero character, was getting older, and the movie is kind of about him getting older. He's caring for his mentor who's in a wheelchair. So I'm watching this and I see this big superhero Wolverine, lean down, and he picks up Professor X from the wheelchair and he helps move him from the wheelchair to the bed. And I'm just like, oh my gosh. And I'm like elbowing my husband like, hey, this is a caregiving movie, because these are the kinds of things that caregivers do. And then the more I thought about it, the more I asked myself, is this something that is Wolverine the kind of person who's going to raise his claw and say, yes, I'm a caregiver and I need help? And this comes more real as we really get into the community. This is a young man, Kevin, that I met at a rare disease conference a couple of years ago. And he has spinal muscular atrophy, which is a disease that causes muscle wasting. So he has weaker arms and legs. And he had always wanted to go on a backpacking trip around Europe. And so his friends actually built a backpack to carry him. And he went with this group of guys on this journey through Europe, and they filmed it and they made this wonderful film. And I had the chance to listen in on one of the film screenings. And I asked his friends, do you think of yourselves as caregivers? And they all said no. Let's go to the next slide. I think that comes into really understanding what care looks like in terms of a service delivery model. So care is truly multi-directional. We talk about it sort of like I take care of this person, but there's always a give and take in any human relationship. And so this is some work that's been done out in Palo Alto to really map out those caregiving relationships and further identify how those relationships look. So you can see, for example, here we've got Nate who's caring for Patty. Nate has a brain tumor and he's in his 30s. Patty has MS. So they're both caring for each other. And there may be other people like Patty's mom and Patty's friends who are caring as well. On the next slide, you'll see an expanded version of this idea that sometimes care is not just about two people, but maybe it's about an entire community or a broader, bigger family groups. So you can see here, we've got Laura, she's in her 50s and has type 2 diabetes. And she's married to Fernando, who's in his 50s. Now, they both are caring for his mom, who has Alzheimer's disease. But there's all these other people in that ecosystem. We see a brother-in-law out here on the right. We see parents and grandparents. We see sisters and niece. And we even see, again, with that idea that we're all playing a role in caring for each other, you can see that the dog even made it into this graphic. And there he is, Fernando's dog, who has a bad back. And so I think that those challenges show that the care is multi-directional. So as you're thinking about that, if you'll go on to the next slide, I want to give you the definition that we use for caregiver. Now, this is not the be all end all. This is a concept that, like, much of our family is evolving. But this is from the Raised Family Caregivers Act, which creates a national council at HHS to define this national plan for family caregivers. And they're particular here. They're saying that it's an adult family member or other individual. That could be potentially a child. It could be a friend, a neighbor, who's caring for someone because they have a significant relationship with them, and they're providing broad range of assistance. And typically when we talk about caregiving, we talk about chronic disease related to health conditions, disabilities, or functional limitations. And you can see some considerations there on the right for other types of caregiving situations that may sometimes get left out of definitions. This is actually a very hotly debated topic among caregiving folks, and particularly researchers. Specifically, are we talking about parents of kids that are able-bodied, or are we talking about only elder care issues? And the reason I raise that is from a service perspective, sometimes people may not be aware that a program like the National Family Caregiver Support Program, which is under the Older Americans Act, might be able to benefit someone who's an adult caring for another adult with a healthcare need or disability. And so just to keep that in mind as you're sort of dealing with these identification and marketing issues, and you're thinking about how to reach people. Now on the next slide, one last definitional thing, and I just want to talk briefly about cultural competency. So we've had the pleasure of being able to work with a broad group of folks from around the world. And my counterpart in Taiwan, who is a professor who studies caregiving and family support, but also leads a caregiver coalition in Taiwan, has profiled some of the work they've done to create essentially a care cafe. So the idea that you could go to a coffee shop and connect with other people, and that you could get resources on how to provide care and how to help your family. But the thing that really stood out to me is that in many ways they had to create new ways of talking about caregiving, because the idea that you would choose to take on care, or that you are in a role separate and apart from your family role, is not a culturally literate view. And we see that in the United States across multiple different kinds of populations. So that's one additional thing to just keep in mind, is that the way that we talk about this, to recognize that if you're so selfless that you're taking on care, you may not even recognize what you're doing as above and beyond what others are doing. And you may not feel comfortable asking for help. So let's go to the big picture on the next slide and talk about some of the data. We do a report with AARP every 5 years on family caregiving. It's a statistically representative sample, which means we can project out what we see as trends across the United States. And there's three big trends that you should be aware of when it comes to family caregivers. When we compared the data between now and 5 years ago, more people are caring for 2 or more folks. So care responsibility is increasing. People are caring longer, on average 4.5 years longer than they were 5 years ago. So people are caring longer than ever before. And more people are caring in general, an increase of 9.5 million new caregivers from when we looked at this in 2015. Now, one thing I'll note about this study, if you happen to go and read through it, and let me say it is a captivating report, and there's a lot of richness to the data, is this was fielded before COVID-19. And there's some early research that indicates that there's actually a higher number of caregivers now since the pandemic began. So let's go to the next slide and just take a glance at the pressure points that are facing caregivers during crisis. Now, this is a project that actually the National Health Council is on the steering committee for and has helped us develop, but it's the beginning of a framework to describe where are the pain points for caregivers and how do we match up solutions for those pain points. And what I want to call attention to is over here on the right-hand side, you'll see this caregiver under the cloud that says pressure on home, self, and family. And one of the things that came up as we workshopped this framework with researchers, with innovators and business leaders and tech entrepreneurs, with advocates and coalition leaders, and with real people, both in a national community town hall and a global town hall. Something that came up again and again was food security. And you can see that little cloud. It almost looks like he's looking at the cloud that says security. And there's a concern there about income and financial security, housing, and food security. So this is a pressure point that's amplified by COVID-19. On the next slide, I want to share with you some data that supports some of those pressure points that we saw. So this was a multinational study from a group called Embracing Carers. It's an initiative of EMD Serrano, which is a pharmaceutical company who's been leading this global effort around healthy women, healthy economies, and the role of caregivers. And in this study, this is the US-based data of this study that was fielded in a number of different countries. It's representing about 750 different caregivers here. And they asked them about pressures related to COVID-19. One of the things they found is that more than half of caregivers said that the pandemic made their financial health worse. And that one of the big pressure points there is food. More money going to pay for food than before the pandemic. And you can see some of the other financial impacts there. If you look on the next page, so we know food has a financial impact. We also know there's a health impact that's interwoven with that. So almost half of caregivers said the pandemic worsened their physical health. And you can see that out of that group of people, out of that 44%, about a quarter said they can't afford nutritious food. So you can see that there's this interrelationship between the idea of what I can afford to eat, to buy, to purchase, and what I actually am able to eat, and that impact on malnutrition. On the next slide, you'll see that there's a heightened impact, particularly on women, that women in particular tended to shoulder more of the caregiving activities and the strain related to a burden of disease, and that women were more likely to report than men that they were spending more money on food. So you can see these sort of traditional gender roles sort of coming back to the forefront in the midst of this national and global crisis. On the next page, I want to share a little data from a different report that was done by the University of Pittsburgh. They actually have a government grant to support work around family support. And they likewise fielded a survey to identify what some of the COVID-specific concerns were for family caregivers. What I like about this research is it compares caregivers, there in the blue bar, to non-caregivers in the yellow bar. And I think the first thing that you can take away from this is all of us are feeling stressed with the pandemic. All of us are tired and exhausted and don't want to do another Zoom meeting and what have you. But I think what this study really talks about is that caregivers have that much more additional pressure. And you can see that here in this question about worries. And it's not just the idea that people are worrying more and they're spending more time worrying. On the next page, you'll see that worrying has a direct relationship to behaviors that people might be taking. So there's a lot of behaviors here on this slide. I've tried to call out the food piece, but you can see things in the way that people change behaviors where caregivers stand out. And one of the biggest is that caregivers were more likely to say that they were stockpiling food and water. And then you can see a breakout here as well of those caregivers that caregivers said they were more worried about even having food, being able to pay for food. They were more likely to be worried that they felt food didn't last, or that they didn't have money to buy more food, or that they would run out before they could afford to buy more food. So you can see how that emotional impact really has a direct relationship with how people behave and their ability to get nutritious food that they might need. On the next slide, it's just a couple of qualitative findings and statements from the report, just to give you some pictures of some of the impacts around food and nutrition in particular. You know, the idea that you're having to do more shopping as a caregiver because the person you're caring for might be immunocompromised or might be at risk and can't go to the grocery store. The idea that you're doing more online shopping. So there's that piece about managing finances and having to take on sort of more of these household chores and activities. And the idea that you're maybe not inclined to eat healthy because you're already exhausted from having to work at home all day or from coming in and out if you're an essential worker. And so you're ordering takeout food or food that might not be as nutritious because you're exhausted. Now on the next slide, one more study I just want to give a shout out to, and that's my colleagues over at the Rosalind Carter Institute for Caregiving. And they did a survey back in October where they asked about some of these impacts with their group of caregivers. And you can see that this is a potential solution that's been emerging that Dr. Chow talked about, which is delivered food. So you can see that before COVID-19, only about 46% of caregivers in this sample said that they were having food delivered, and that number went all the way up to 81% in terms of after. If you look on the next slide, you can see a couple of suggestions that were recommended, and this comes back to that idea of care as a community, not just a one-to-one relationship, because some of the things that were identified by caregivers as helpful were things like having friends and family help with food deliveries, getting food assistance or financial assistance through charitable donations. So that could be something like Meals on Wheels. It could be a gift card or another community-based program, such as a food bank or you know, a program that's through a faith community in your neighborhood. And that piece about contactless pickup and delivery. That was something Dr. Chow talked about earlier that I think is really key to helping people feel safe and not adding additional strain. On the next slide, just a resource that you should be aware of if you aren't already. It's the Defeat Malnutrition Today Coalition. And they've got a lot of information about food assistance programs, as well as a national blueprint for achieving quality malnutrition care for older adults. And while their focus is on older adults, some of these resources would apply to people with disabilities of any age or health complexity. They also have a COVID-19 specific page to help people get the assistance that they need. And then on this next page, just a couple of resources that are broader in scope about how to find information about food and food systems. And I'm linking here to the CDC, to USDA, and to the nonprofit organization Feeding America. And then finally, for those fellow research nerds out there, I've just included a slide with some of the citations to the research studies that I shared in this report. And that's it in a nutshell. I'm so thankful to have had a chance to talk to you a little bit about caregiving and looking forward to the discussion.
Thank you so much. That was really terrific. And thank you to Shirley and Grace both. We're going to jump into some Q&A now. So there is a question here in the Q&A from Debbie Drell. And her question was, how do we bring that care cafe concept to the United States? She says that she loves this idea. Debbie loves this idea. And I was intrigued by it too. I was like, what a great idea. And you can think about how you could pull this off virtually if you had to. Grace, would you comment on that?
Yeah, absolutely. You see some care cafes in the United States, particularly around dementia. I know Massachusetts has done some care cafes programs in particular, and surely maybe you have run into them. One of the things I like about the Taiwanese version of this is they've thought about ways to make it very tech savvy. And so there was a discussion, for example, that you would come in and you would get coffee, and the coffee, they would also hand out instant coffee. So it would say respite coffee on it. So the idea that you could take a break when you're drinking your cup of coffee. And they also had talked about on the art in the cafe, doing something like having a tree with a QR code, and you could scan the code with your phone and be connected to various resources online. And so I think there's a lot of opportunity there to kind of play around with it. And I would encourage you to check out the link in that slide to the profile to learn more about their program.
And this might be something, Grace, that maybe some of the patient groups could do on a local level, because some of them have local chapters. And so maybe there could be a cafe at a local level with the local chapter.
I mean, I think honestly, it could be super fun. You know, I've even things you daydream about, like, you know, there's pop-up cafes and food trucks. You could do a food truck related to nutrition, and Shirley, maybe you've seen some of these things on the community level.
Actually, that's a great question. I know during the COVID, at least the Massachusetts has this caregiver support group. I think they call in, and like I mentioned to you the other day, normally the caregiver, they need a support once a month, now almost like a weekly. They need that support. One is for their own health to navigate all the services available, and others are just moral support. I think the peer support among each other, probably. That's the most important thing. Yeah. Interesting, you mentioned the Taiwan group. Yeah, years ago, I came from Taiwan. So that is in the culture, you sort of, you take care of the family caregivers. Yeah.
Shirley, I had a question for you. You know, as I mentioned a little bit earlier, many of the National Health Council's membership in the patient advocacy group category, we work predominantly with the national offices and work on a national level, but many of them do have state level affiliates and local chapters. And I was wondering, in terms of the work that you do for the state, if you do anything in collaboration with some of those state chapters of patient advocacy organizations, and the connections that might happen there.
Yeah, I think a couple big support for local programs is the NANAS, the National Association with Nutrition Services, and also I think Grace mentioned the Defeat Malnutrition. They were big support on a lot of services we do, and Meals on Wheels American is also, most of our programs is a member of the National Association. And as far as
it doesn't look like there's any disease-specific groups that you work with.
That's a good question. I think Alzheimer's Disease Association, we work with it, and
Association? Great.
yeah, and probably in my office, I would say the caregiver with other association, that's individual chapters, they do work with. Yeah.
That's great, because I'm thinking that in terms of our membership, you know, that's part of the audience for this call, that we'd want to think about ideas that we could give their local chapters in terms of working with state organizations that deal with nutrition and caregiving issues, and whether or not there's some examples of that being successful in some places, and how we could hold that up as a model for others to learn from.
Yeah, that's a good idea to think about. Yeah, that's right. Yeah. So, yeah,
we have
to think. Yeah, we sort of more work with the state associations on the nutrition part, but in the other group, I think with the entire elder affairs, they are part of the national organization. Yeah.
There's another question that's come in from Kelly Bond. Kelly says one of the learnings during COVID was reaching out to both familiar and new community partners. What are some suggestions that you both might have to keep this going as we continue to move forward? Many times you find that initial assistance with each other tends to go away because we have a tendency to kind of go back to our own habits, our old habits, our own silos. So what are some of the things that can happen to keep the momentum of this networking and contact that started because of COVID-19, but after COVID-19?
Actually, I think that is a great question. That's what we were thinking too. We have some rural communities, because it's COVID, all of a sudden show up, the healthcare organizations, the community, the government funded, some private funded organization all team up together. After the COVID, that's also, we were thinking, what's what's the next step? We can keep this strengthen up this group and continue the efforts. I all can think is COVID give us a good example, good model. How can we work together? Maybe some programs, some collation should start set up now, and to after May or sometime this can keep going. It's really surprised, especially in the rural area. We found out more resources showed up and more seniors using the services, and never happened that before. So maybe that's one positive thing from COVID, and we just have to figure out a way keep going. Yeah.
Yeah, we've got to think about those kinds of things. Grace, comments on that?
Yeah, I mean, it's interesting. Shirley, one of the things I loved about your presentation was, how you were taking old models and just rolling with it, but modifying it. And I think one of the things that many families are facing, I mean, I have to chuckle a little because it took my parents and my in-laws forever and ever, and I would say, let's have a video chat, because they live on the other side of the country. And it was like, no, we don't, but then once Zoom happened to all of us, it became much more comfortable, and it sort of forced us to innovate in new ways. And I think when I think about something like nutrition, and I'm just sort of also looking at some of these comments in the chat, there are a lot of family activities, for example, that you could do cooking classes remotely, and then as things open, do some of those in person. Or my mom and I will do a remote shopping trip, where we're screen sharing and looking at things that are on sale, and so I think there's this opportunity to get at isolation with food in particular. And some groups like the American Cancer Society have put out cookbooks, for example, where it's how to cook for someone who has cancer or is in recovery for cancer. And I think thinking about those creative ways, especially if you have a population that maybe has a condition that has really specific food needs, and when you're having those conversations, to also be talking about how is it that you can modify favorite recipes to make them more nutritious for your family member. And a lot of that is going to differ from family culture to family culture. I know I grew up in the South, and I love like fried okra and ribs and banana pudding, and so some of these things are not the most nutritious. So how do we still have that family togetherness around meals, whether it's Thanksgiving or Sunday dinner? And how do we make sure that the food is nutritious and it's supporting other things we want to do as a family? And people get very emotional about food. So I think taking some of those opportunities now to eat together virtually and to cook together virtually can also lend itself to new kinds of programs when we get on the other side of the pandemic.
Yeah. I think it's just one thing, like we always want to do outreach. And during this pandemic, we found out we somehow connect with the veteran services and with the ADRC. It's a lot of services we never jointly work together because nutrition is a separate issue. Everybody, you're right, it's our silos. But because all of a sudden we found out we have the same needs and we can provide the services jointly.
Yeah, it's one of those bright spots that's come out of the pandemic, this collaboration. Therese Schollard has offered a comment that's very much in line with what we're talking about. Therese says, on the diagram with the bubbles, for the food/nutrition gray cloud, off of that is the issue of many patients needing more attention to their nutrition, such as adequate protein for various diseases. And caregivers are supposed to know how to do all these modifications to prevent malnutrition. And they often don't know this information or how to manage the meals and the mealtime and the food prep. This occurs for many people, not just those who are food insecure. And so I think a couple of the things that you were both touching upon kind of gets to this, how there's opportunity to do some of this virtually. There's opportunity to do some of this in collaboration with other programs. Do either of you want to comment on how do we help those caregivers and what they're supposed to know about these nutrition needs, which has to do with whether or not someone is food insecure. You know, that malnutrition issue, as one of you showed the photos of people saying, you know, I may look fine, but I have malnutrition and because of some of these specific needs. Can you both comment on that?
Well,
Yeah.
yeah, and we did a study a couple of years ago on caregivers of people with inflammatory bowel disease, and that could be ulcerative colitis or Crohn's disease. And of course, there's a lot of diet-specific information there. And that was something that came out in some of the qualitative responses, was just the challenges in trying to learn how to prepare the food and how to navigate even things like going out to a restaurant. You know, what can I order? And you know, how do I do that in a way where I don't feel embarrassed or my family member doesn't feel embarrassed? So one of the things I think patient advocacy groups can do that can be really helpful is to provide information to people on those kind of topics. I also think it's interesting because there's a bit of a generational divide in that a lot of younger people just don't have a lot of skills around, and I'll throw myself as a millennial under the bus here, but there, you know, you see like the rise of commercial products like home delivered meals for young adults, where it's like, here's a kit and everything you need to know how to cook the stuff in the kit. And, you know, here's the instructions of the recipe. And I wonder if there are opportunities there to think about partnerships with some of those types of companies. Because as far as I understand it, even the congregate meals programs from a regulatory perspective are only for older adults. So, you know, if you wanted to have the same meal with somebody in your life and it needed to be a specific meal, there's probably opportunities for groups to get out there and share some of that information.
Yeah, that's a great idea. Thank you for thinking that way, Grace, because that was going to be my final question to both of you is, what can the patient advocacy organizations do to help support the work that both of you are doing? And so, Grace, you provided that comment of patient advocacy groups can provide some of the information about the nutritional needs of people with certain diseases, and not just, oh, you have a nutritional need, but here's some ways of addressing that nutritional need. Other things that both of you could comment on in terms of advice to patient advocacy organizations?
Yeah, another thing I think with the caregiver, I try to find a couple web links. I think Abbott Nutrition has a really good site for the caregiver on how to take care of the people they take care of it, and also for themselves. And I think years ago, it's also as a work group. I try to remember the group name, but they also have a very comprehensive for the caregiver wellness needs. So if I find that, I send along to you. But for the advocacy group, I think the best thing is to look the whole person, not only elderly. It's the whole person. It's the entire lifespan, and we all can work together on treating nutrition and wellness, and the chronic disease management as one issue, and not segregate by the ages group, because we sort, especially with caregivers, everything, we all interact together. Yeah, so.
Great. I think we're at almost the end of our time, so I think we're going to have to stop very soon, but I wanted to give Silke an opportunity to answer some of the questions that have been coming up about slides and the recording. Silke, could you jump in to answer some of those questions?
Yes, no problem. Thank you. So the webinar recording will be posted on our website in about 1 to 2 days, and you'll be able to find that located on the National Health Council website under resources and webinars. And it should have the title, and you can find the recording there. And we should have it up by Friday.
Great. And then one last question that I see popped up that I think is an interesting one that you both might want to comment on. Periodic malnutrition screening. How about some thoughts on ways to help patients, especially through the patient groups, through periodic malnutrition screening tools? Do you have thoughts on that?
There is, okay, I can briefly mention, it's really interesting. Early days, our Malnutrition Commission did a target survey with all the long-term care facilities. Now we found out they do ask the question about the weight and appetite, but it seems like about 60% people unaware is a screening tool. So I think that's very important if we can getting that standardized and promoted. Also, there is a frail scale. That's also important, I think, for the patient care can use that too sometimes. And that's a very important issue. And I think that's one way to connect with the community and the healthcare profession to benefit the patient, to bring this message and to increase the overall well-being. Yeah.
I think too, there's a chance here, again, coming back to how we communicate, to educate the families that you might be working with, that might be an option at the doctor's office, because in Shirley's slides, that piece around like, I don't look, skinny, or you can even be overweight and be malnourished.
Mhm.
And I think the other side of that is to remember that there's a behavioral health reaction that a lot of families will have, because if you have a couple and they both have type 2 diabetes, or and one does the cooking for the other person, that it's not just a lack of knowledge, but it's helping the family recognize that things that they might be doing that celebrate with food could maybe be celebrated in other ways. So like activity and healthy eating as part of sort of a more holistic approach, to recognize, like, you may say, oh, well, what's the big deal? Dad's 70, he's going to have 3 pieces of cake. But to help those families be equipped with other things they can do to celebrate, and to pair it up with knowledge about when you're at your physician, you can ask them to check in and see, how's your nutrition going as part of your overall wellness. And I think that could be a helpful way to start that conversation.
I don't know, Grace. I come from a big Italian family, and we don't know how to do anything without food.
It definitely.
I want to thank you both for this. This was really great. We really appreciate your time and spending it with us, and your thoughts on this and the advice that you've given us. I want to remind everyone that we are going to be having a second nutrition-related quality measures webinar that will be happening, another webinar based about nutrition. Silke, we don't have a date on here. Could you jump in and tell everybody what the date is so that they can mark their calendar?
Yes, absolutely. This is on April 9th at 12 p.m.
At 12 o'clock in the afternoon. Okay, great. Thank you very much. Thanks everyone for joining us. We really appreciate it. And thank you to our speakers. Let's give them the applause that they would normally hear at an event like this. Thank you both very much. We appreciate it. Bye.
Thank you.
Bye-bye. Bye.
Bye-bye.
Bye.